Is there sound here?
Yeah, there's no sound, Linda. Or
Sorry, I did it again.
that's all right. Still no sound for us.
There's no more sound.
All right.
Okay.
We're on.
Can you hear me?
Yes.
Okay. All right. Well, thank you, everybody. And I just want to announce the Arthroplasty Motion Preservation course that's going to be held in Seattle this weekend. Please register and show up. It's going to be a great course. You can see cervical ADR with multiple demonstrations, lumbar ADR, ALIF, and cervical laminoplasty. Again, this Friday and Saturday, October 21st and 22nd. Next, Linda. So I'd like to welcome everybody back to our last arthroplasty meeting for the year. And we're really excited to have both Thierry Marnay and Roland Garcia. So these handsome guys have very graciously agreed to participate in the very last meeting, and we'll talk a little bit more. Next slide, Linda. So this hour is going to be dedicated, go back one, please, is going to be dedicated to extended indications. And we've been doing lumbar disc replacement this March, 23 years in the US. Thierry's been doing them since the mid-1980s. But we're very proud to have Thierry Marnay from Montpellier, and he currently is in Milan. It's almost 2 a.m. there. So Thierry, thank you very, very much. Thierry's the inventor of ProDisc and knows more about ProDisc than anybody in the world. And we thank him for staying up very, very late. And also, I'm proud to introduce Roland Garcia from Miami, Florida. He's the co-inventor of ActiveL. These are the only two lumbar disc replacements that we currently have for use in the US. I've asked both of them to discuss extended indications beyond the usual FDA recommendations. Again, we are now 23 years into using artificial disc. Next. So we looked at our own series of a 20-year follow-up of nearly 1,800 patients, and we found that our revision rate was a little bit more than 1%, and half of those revisions were really based off our learning curve. So although Thierry Marnay's numbers may be a little bit better than ours, it's less. If you take away the learning curve, we are less than 0.75% in terms of revising the disc at those levels. So it's a very, very durable implant. We're not seeing loosening. We're not seeing osteolysis. We're not seeing anything horrible. Next. So this is a 20-year follow-up of a Charité, not my prettiest. I could have done a better job in centering, but that was a problem with the disc. But this lady came back for her neck, and I said, can we x-ray your low back? Next, Linda. So this was a tough patient. This was a 33-year-old girl that had scoliosis surgery as a teenager, and she had severe chronic low back pain for 10 years. Somebody offered her fusion, and whether or not they were going to do a bedrock procedure, who knows? But at 33, she couldn't take care of her kids. The MRI scan showed the L3, 4, and 4-5 levels to be completely normal. L5S1 was totally burned out. So we did the arthroplasty, of course, after Thierry's blessings, and so far so good. She's absolutely wonderful. She can take care of her kids and very, very happy. Next. And then the last case, this was a 43-year-old, again, very miserable. She was a trainer. She had many, many years of conservative treatment. Somebody offered her a multiple level fusion. And I asked you, what is better than offering her a multiple level arthroplasty with a single level fusion at the bottom? So that's sort of an introduction of where we're coming from. So I'd like to introduce my good friend, Thierry Marnay, all the way from Paris at 2:05 a.m. And Thierry is going to give us a talk on extended use, and he'll go for it. Thank you, Thierry.
Okay, thank you for your words of introduction. Yes.
Perfect.
Okay, thank you for your word. Yes. As a matter of fact, despite my long experience, I always ask myself to question about extended indication, which is normal, and it is our everyday reality. It's important to understand that in my mind at the beginning, as I was a scoliosis surgeon, I did not want to fuse people to the pelvis, and I was wondering what to do to spare some levels. It's after this reflection I realized that also we could treat the lumbar disc degeneration with an implant. So that is my experience. And we have to think first about the biomechanics of those dislocations, because I will focus my talk on scoliosis and total and degenerative spondy. We have the rotatory dislocation. Here you see on the left, it's a open dislocation. On the right, it's a closed dislocation. That means that we need stability inside of the implant, whatever we choose, and we will need something that is very, very strong for its anchorage. Probably is the origin of the fixed core and the keel. If you look to this context here, we have an horizontal instability, very important, remaining some motion. The stenosis is not a problem on this case, but also here we will have to maintain the stability and the fixation. Stability is a fixed core with a ball and socket, fixation is a keel. The keel, especially in those rotatory dislocation, is very important because it will stop any rotation of the disc itself. After that, the ball and socket will reappreciate the curve and the course and the race of the facets by driving them around the center of rotation that has been determined on the ball and socket. So whatever the facets are, they will be discharged by the reduction and the distraction of the space, and after that guided for their motion, so there is no risk of facet guiding of the motion, which could be very, very bad in that type of cases. We will limit the shear forces, limit the dislocation forces, and limit the displacement of the implant forces without limiting the motion of the implant. So there is, to achieve that, and each time somebody is asking me, I have that type of case to perform, what should I do? My answer is, the most important is to implant and perform your keel cut in a position of reduction. So reduction for the lateral dislocation and or the rotation, reduction for spondy and the anterior slipping. It's very important, so to make your cut in a perfect reduction as much as possible. And so the keel preparation. But after that, when you introduce your implant, you must maintain this space open by lateral osteotome put vertically, by a strut, whatever, because at that moment you are sure that what you see is what you get, and that means that what you see on your fluoroscopy or as a reduction with what you get when the implant is in place. In scoliosis, I operated 205 patients below scoliosis and in scoliosis conditions. Some, as has been seen, been showed by Rick, long time after teenager instrumentation. Majority at the adult time when they have the scoliosis that is painful and degenerate and dislocate, and below the scoliosis, disc that are damaged by DDD, but probably more by the evolution below a scoliosis. So I hate to fuse to the pelvis, as I told you, and so I have started to put some disc inside of those spaces below scoliosis, and sometimes inside at the beginning. That is my series of 205 patients. As you see, you have more females, 165 than males. You were expecting this statistic. You see the idiopathic, so 112 scoliosis and only 43 degenerative scoliosis, and pre or posterior surgery 50. 1 level, 2 levels, 3 levels, because not only one space is damaged. I often cover the last, and you will see it on the examples. I often cover the last instrumented space by an ELIF to have a transition very, very strong for my fusion, because a fusion above something you want to remobilize like a disc needs to be protected, and that's why often I perform an ELIF over the total disc replacement. Result, ODI pre-op 24 and 15, finish at 10 at 24 months. And you see the vast lumbar 7 to 5.7 and 7.2 in lumbar, and finished to 2.6 in post-op. The same for the radicular pain. It's good because you don't choose a sagittal balance for the patient. He will choose his or her sagittal balance by himself or by herself, which is probably more appropriate than to decide for the patient, because our decisions are not always exactly what we wanted to do, because surgery is not always successful to restore the lordosis, but also the patient will choose by himself, especially determines sagittal balance on a scoliosis is not always so easy. It's perfect on the images, but not always perfect for the patient. I had only 2 cases where I revised screws, and I removed 6 times the posterior device. Okay, that's an example. It's an old one. You see, not the screws are only for the lumbar. You have double hooks like clamps on the thoracic spine, and you see the reduction of the quality of reduction of the scoliosis with only 4 points up and 4 points down of fixation. And you see an ELIF. Here it's, I think, Synfix, and total disc replacement. And you see that the total disc replacement, with the small inclination remaining, is very, very protected by the fixed core and the ball and sockets. Here you see the quality of the mobility. I heard someone who says, oh, a ball and socket, today, a ball and socket doesn't move laterally. Yes. You see here you have 12 degrees of lateral inclination of on both sides. Okay, you have here the quality of the result, and the reason why is very good to spare 1, 2, or 3 levels below scoliosis if you can, and not to fuse to the pelvis. The patient will be thankful for his quality of life. Here the same, it's a 56 years old woman, 70 degrees, never been operated on, because when her parents didn't want any surgery, but it was probably a good thing, because at that time it was not very, very satisfying. She has a hollow back with a hump. You see also the retroversion and the incidence angle. That's the result with a complex instrumentation. You see that it remains a rotation in the inferior, and that's why it was a discussion we had with Rick Gaia. That's why you see the prostheses are not aligned. Yes, they are placed on each level and not placed to be comfortable for the X-ray, because the rotation oblige you to be in the axis, and sometimes the rotation is fixed and complex, especially at that age. Here's interesting. I operated this woman when I was very young, 32, and she was probably around 30. And she had, so you see, you can imagine my age now with an Harrington rod. And okay, everybody was telling me it was stupid to let only 1 level L5S1 and not to fuse it. And I say, as long as this level works, it's okay. During the time it will be destroyed, I will have invented a disc to change it. It was like a joke. but probably not only a joke. I had that in my mind. 30 years after, she has completely destroyed L5S1, as you can see. I put a disc. Oh, the facets are ugly. The prosthesis is a little bit inclined, but as you can see, it moves. 18 in extension, 2 in flexion. That means 16 degrees of motion. I can tell you that she recovered motion she have lost over the last 15 years, and she was very, very satisfied. After that, by chance, she had a good bone at that level, because if you have a very bad bone after such a long fusion, it's not the good way. And as you can see, the ball and socket discharge you of any concern with the facets. That's very, very important. This one is easy, you see. It's a young lady with a scoliosis. You treat the scoliosis, and she has L5S1 destroyed. Probably nothing to deal with, to separate pathology. So you do it in the same time. That's my result for scoliosis, for 48 to 20 for the ODI, 7 to 2.6 for the VAS, and 5.7 for the leg pain to the 2.1. Okay, so it's very satisfying because the patients, you know, a disc of 20 degrees of disc and or 40 for 2 levels change completely, 40 degrees change completely the life of the patient, because you can see that it's probably 40 degrees, it's probably 30 centimeters of difference when you want to touch the floor. So in one hand, you buckle your shoes, you cut your nail, and you have your own, you can take care of yourself. If you fuse them to the pelvis, don't think that the hips will take all you can. The mobility of the hips will be perhaps 16 degrees if they are very, very, very flexible. So semi-constrained prosthesis, skill, fixed core. The technique I described to put it in place, take care about the quality of the bone, especially of patients who have already been operated on, because sometimes the spine forward is osteoporotic. Diagonal spondy, okay, it's the same thing for one level. But here you don't operate below the pathology, you operate inside of the pathology. So you have your instability of the space, and you need to neutralize the shear forces, to restore the height, to discharge your facet, and guide with the fixed core the race of the facets without contact, if possible, between them. That is an example. You see, you have always some, sometimes you have big stenosis. Here you have only soft tissue stenosis. So the decompression by anterior approach and the disc resection, plus the restoration of the sliding, plus the restoration of the height, will allow you to treat and decompress by anterior approach here. You see the good motion. Those spondy have always good motion in pre-op if they are not in acute pain crisis. Here you see 56 degrees of pelvic rub. That means participation of the pelvis to flexion extension, 85 degrees in extension, and 22 in flexion for the lumbar mobility. The L1 race is, that means the race of L1 from extension to flexion is 125. It's very high for a pre-op. It's there that we see that the spondylodegenerative have nothing to do with the degenerative disc disease, because those are stiff. And that is a two-level construct because of the status of L4, L5 with the perfect motion post-op. And you see L1 race 140. This case is an old case. She has very bad facets. She has been operated in 82, something like 92, something like that. So that means 30 years. She had a stenosis because of the spondy. She was in her car all the day because she was working as commercial. And we had a good motion after the surgery, 15 degrees, but we have also, you see, the control at long term, the reshaping and now the facets are more frontal. That means there is a reshaping of the facet because of the direction given by the fixed core. This one is interesting because it was the first prosthesis of my partner, those who know him, Guillaume. And Guillaume presented that, say, boss, I have found a good case for a disc. Yes. For the first disc in your life is perhaps, well, okay, I will be there. I won't let you alone with that type of case. You see the dislocation, you see the 3 levels disease, the stenosis 3, 4, 4, 5, and the spondy 4, 5. Okay. And real stenosis. Okay. 3 disc. We see the repositioning you see the repositioning on the right part of the slide. We distract the facets. There is a space that appears in the facets. So we have not to be desperate by the facets. And that's the long term. 11 years post-op, you see the facet of the patient.
Terry,
yeah.
Terry, can I ask a question? So on these cases with stenosis and spondylolisthesis, are these back pain patients or neurogenic claudication? And if they're neurogenic claudication, do you do a decompression as well, or just the prosthesis to indirectly decompress?
Indirectly decompress here. Because there is no big calcification or bone inside of the canal when you analyze precisely. It's just a displacement that make you think you have bone in the canal, but if you put all the pieces of the puzzle in good place, it works well. So 11 years after, you see the facets of this patient, a bit different than before, but whatever.
And what happens after you do the prosthesis if they still have some bony stenosis and some neurogenic symptoms?
As you have seen, I will come back if I can. Yes, you see, I have made a radiculogram control to be sure that there is no remaining big stenosis compared to the pre-op. If it remains, I make a mini invasive decompression, endoscopic decompression now. It's not it's a complementary small action that will I will say easier than before because it's no more it remains only sometimes it can remain one spot to decompress and not the 3 level laminectomy that I would have performed before with 2 lines of screws. And you see the quality of the mobility and you see the quality of the stability, especially in flexion, for this case, very unstable in pre-op.
Terry, you don't mostly worry about how old are these patients?
This one, I will tell you, I think it was at the beginning.
63.
Okay, 62.
And do you do DEXA scan?
Oh, yeah. My friend Jack, who is there, taught me that the most important is the quality of the bone. After that, you can do what you want. He's right.
Terry, how about the orientation of the facets? Because on the slide you had with the 2 rows, the upper level, the facets were very sagittally oriented. Yeah, the last slide, the one before this. Yeah, they were very straight ahead if you look at the upper right. So do you not worry about that allowing anterior translation with the ProDisc anteriorly?
No, for the moment I have never unsnapping or dislocation of the poly on that type of cases. I think there is 2 reasons. It's not L5S1, so the sacral slope is your prosthesis is more horizontal, so there is less solicitation. Probably I would be more, I would say, prudent or careful. and modest in my choices if it was L5S1. After that, you know that we have for a long time by chance 3 and 3 degrees. That makes the degree in the inferior plate that protects you about any damage on the poly with shearing shear forces that push. They would like to push the poly out. But I have never got any dislocation in that type of cases. Okay, this case. You see here we have a stenosis, but the stenosis is more soft tissue and thickness of the ligamentum flavum, a bit of bulging of the disc. There is no bony issues. The thickness of the ligamentum flavum is because of the collapse of the disc, and it's, I will say, it plays a role of a curtain that is too long. So at that moment, when you restore the height and the positioning, you will have a good result. You see here the positioning of the ligamentum flavum that we see perfectly in the canal and this MRI. So with the reposition of the spine and the retention of the soft tissue by the distraction, you will get what you expect. That means an opening of the canal. You see, oh, excuse me. You see here on the CT on the left side of the screen, you see that you have also a small lateral dislocation. That's why I'm very, very careful about the positioning of the trial instrument. Very careful about the release. And when I put the disc, very careful to open the spine by lateral struts that will help to insert your disc in a perfect position. You see the instability, but also you see it maintains some mobility. The flexion is not very, very interesting here because there is not a lot of flexion. I don't know if it was the pain of the patient or a part of compensatory stiffness. And you see the quality of the correction, the quality of the reduction, and that is the guarantee of the result. And the guarantee of that type of motion post-op. You remember how it was before? Inflection, and that is the flexion post-operative, that you recover. And so those who have already heard my presentation and discussion about that, you recover your pelvic mobility and your lumbar mobility if you put a disc that no fusion can restore. There is no compensation above and below after a fusion. Okay, you see here the quality, 50 degrees of pelvic motions, 76 degrees of lumbar motion, and 130 degrees of L1 raise. That's it.
Thierry, I think you may have already answered this, but in which cases, if any, would you do a decompression?
If I have to perform a posterior decompression, I think I don't put a disc. If I have to in pre-op, because my indication for posterior decompression in pre-op is bony stenosis. That means arthrosis has grown inside of the canal with osteophyte in the canal that are making a truffle design of the canal diameter, and at that moment, if there is bone that has grown in the canal, I am not very tempted for this acrobacy. if it is only a post-op, if it is only a post-op that remains and the patient has some pain and the radiculogram shows me a compression, I perform a limited posterior decompression today with an endoscopic technique.
May I ask a question on the scoliosis
Yeah.
patients? So obviously, before we get to Rolando, because he's got to get his talk going.
Scott,
So my question is, you have the scoliosis patients that the scoliosis surgery ends at T12, L1, L2, and they have an L5S1 degeneration. And I think we can all agree that a prosthesis would work well there. But what if you have multi-level degeneration right below the scoliosis fusions? Can you go, if the fusion ends at L2, can you do L3, L4, L5 prosthesis right next to it? Or is that too
Yeah.
much biomechanically
Yeah.
disadvantageous?
On my statistic, you have seen at the beginning of my presentation of the statistic of the scoliosis that I had several 3 levels. Yes,
okay.
it's not the
Terry,
majority.
Terry, why don't you finish up and then we'll move over to Rolando and
Yeah.
and then we'll still have time for questions. So
Yeah.
finish
Mine
your-
is mine is much briefer, so you can give.
okay,
Terry-
but I know Terry still has more stuff. So go ahead, Terry.
No,
Finish up.
no, it's almost done. So that is the quality of the result when you perform your ODI and your VAS. No comments about that. Okay, you see, it's done. It's we have nothing to lose. We have nothing to lose. It's a win-win deal with the patient because he wins, he maintains or restore its mobility below the scoliosis. And you maintain, if there is dislocations below, not included, compensatory curve, the contra curve below, but it's because it moves below a fixed scoliosis that makes the spine works in very bad condition. If you fuse the thoracic spine, and thoracolumbar spine, and you fuse to the pelvis, or you don't restore what you can restore, it's a double pain. You have the fusion because of the scoliosis disease, and you have the fusion because of the degeneration created by the bad positioning of the scoliosis disease. I completely disagree to fuse people to the pelvis each time I could. Here, probably not all of them, because some of them has a L5S1 far away below the posterior fixation, but in the majority of the 200 cases, I avoided the fusion to the pelvis, which is, I would say, probably one of the best things I have ever done in my life for those patients, because to be fused to T2 to S2, excuse me, but when you are 30 years old, it's not exactly what you wish, especially for a man to work or for women, it's uncomfortable. And just think, the most important is the L1 race, to reach the floor, to reach your surrounding. And each time you gain 10 degrees in L4, L5, and 10 degrees in L5S1, that is the multiplication quotient in my studies that you have already seen is probably 3 times 3. That means that your gain is 30, 40, 50 degrees. Remember my last talk, L5S1 fusion makes you lose 30 degrees in flexion. In a global extension flexion of L1, in L1 race, you lose 30 degrees if you put it, if you compare to the disc replacement. That is the average of loss today. And 30
Hey, Terry,
degrees,
Terry, not everybody heard your talk, but Terry gave this talk at NASS comparing 2-level disc replacement with hybrid. And will you go over that a little bit more, Terry? You had a couple hundred patients in that group, and
I let Rolando share his experience because, I started that in 2000. I was a criminal at that moment. I have been sued in front of the doctor's court for improper surgery because I have performed below a scoliosis some total disc replacements. So I thank you, my friends. I feel less alone today in that type of path.
Terry, we'll never let you be alone in prison. We'll all be with you. So we'll come back to you. And that was terrific, Terry. And we really appreciate your insight and your honesty. And I imagine you're not a real fan of the bedrock procedure, huh?
No.
All right. Now we're going to let Rolando go. And Rolando, of course, is the co-inventor of the Active Ls. That's the second one and the only other one that we can use in the US. And Rolando is going to show a few cases, but I want to ask Rolando. So, Terry's surgery is pretty impressive. The question is, do you think the Active L is stable enough to apply it in the same way?
The answer is, I don't know. Certainly, I think it's a hugely convincing argument that the fixation from a rotational standpoint that you get from the keel, I don't think that you can. I don't think you can have a good argument against that. I think that
but you have the keel. You have the keel with the Active L.
Yes, I think that now that with the keel, I think that that's lesser of an argument. The idea of the fixed core versus the mobile core in these extended applications is something that I sincerely don't have an answer to.
Yeah.
I have listened to Thierry and obviously it's impossible to argue against someone who's making such a beautiful and compelling argument. I mean, when I started picking cases for extended applications, I think my extended applications are Thierry's non-extended applications. So it's a very good argument. I don't know. I think the idea of the mobile core versus a fixed core in extended cases where you have rotational and sagittal and coronal instabilities is a very, very interesting question. I just don't have an answer to.
All right.
I'd like to ask a question too. And
Scott Blumenthal
we've always,
show.
Yeah,
we've always.
You know what? Okay, well, why don't you let Rolando give his little talk, and then you can ask all the questions you want.
Fine.
Go ahead, Rolando.
All right. Am I share my screen now?
Yes.
All right. Is it doing it? Nope.
Yep. I just put it.
All right.
Go into presentation mode.
So
Yeah, he has a Mac. That's a problem.
Yeah, I see.
Can you just show the main slide, Rolando?
I'm trying to do. Okay, yeah, I think so. How's that?
Okay, good.
That's good.
Does that work?
Yep.
Well, I mean, I knew I was going to speak after Thierry, and I was already nervous about it. And now that I have heard him speak, I don't know how I was foolish enough to accept this invitation, because that's really a humbling experience. That was a beautiful presentation, and I think that the ability to see what's beyond the horizon, it's really something fantastic. And the only thing I can say is they always say that we can see as far because we stand in the shoulder of giants, and I think we certainly heard one of those giants speaking just now. So thank you, Thierry, and thank you, Rick, and everyone for inviting me to speak. I had the pleasure of seeing and being part of the infancy of this replacement here in the United States, and again here are two great giants. This is me few years ago, standing with Karin Butner-Jans, the developer and inventor of the Charité, who, was, at least, the genesis of this replacement here in the United States. And then obviously Thierry with his first the ProDisc 1, which I think a lot of people don't know what the original ProDisc looked like. And then obviously the second version, that is the one that we're now familiar with. But obviously we have, we definitely have a giant here among us. Before I start speaking about extended indications, I guess it's my word of caution to those that are listening. And I think that the way I think about extended indications is basically like juggling. If you want to juggle, you have to start, with more basic cases. And I think very few people would try to juggle 5 balls the first time they're out there. So, as you see some of these presentations and some of these cases, just keep in mind that, I only have, again, like almost 23 years experience on Thierry, twice as much. So these are
He's not that old.
These are not cases to start with. And then the second part is that I think that lumbar TDR is a team sport. You need the right operating crew, you need the right access surgeon, you need the right table x-ray tech. And so, just remember that when you're trying to do something that's particularly difficult, you don't wait for it to be the third case of the day and have the x-ray tech that is usually covering, the vascular cases. So just a word of caution about that. Now about the case, and this is certainly not, again, a pretty simple case in terms of what we just saw, but this was interesting. This is a 35-year-old finance guy from South Florida that was having, chronic back pain, little L5 radiculopathy. He tried pretty extensive conservative management and really did not do well. So he actually flew to Europe and had a adenesis put in. Unfortunately, he didn't do very well. And when he came back to see me and he said, well, the bad news is that my back pain has not improved at all, but now I can't bend. So he had the problem that he was in pain and he couldn't bend. So I got some flexion extensions, and sure enough, it's a adenesis. It's a and by the way, I have to disclose I was on the adenesis FDA trial here in the US, and sure enough, he's pretty stiff and essentially fused at the operative level, and obviously showing some evidence of this disease down below. So I said, all right, well, let's get an MRI and see what's going on, and this is what's happening. So I guess the question is, Rick, we were going to ask some questions about maybe what somebody would do here, or I mean, I know I have Scott right there, so maybe I can pick on Scott.
Yeah.
Rolando, did they try to do a fusion? Did they put any bone graft, or did you get a CT to check?
Yes, so the CT is next. And no, this was purely just application of the adenesis. They called it a recalibration procedure.
So if you're picking on me,
Yes, sir.
what we're trying to figure out is why the patient's hurting. Is it 2-level discogenic disease that would, after failure of non-operative treatment, be a 2-level fusion or a 2-level disc replacement? Or is there some other pain generator? Did you do any other diagnostics to figure out where the pain's coming from? Facetogenic, discogenic, discograms, CT specs, whatever.
So I did do a CT and a discogram. I did not do facet injections. It's a very good question, and maybe you can tell me what you thought, but I thought that with the adenesis in place, I wasn't sure that the facet injections or any of that would give any kind of significant value. This is the CT scan, the image Second from the right is at 4.5, and the image on the left is at L5S1.
So you said you did do discograms
Yes,
and they were both positive 4.551.
they were both positive, yes.
So, then, I think you got to take out the denesis. And since this is a motion course, obviously we would, with good, nice preservation of disc height, would be a great candidate for a 2-level disc replacement.
Thierry, would you comment at all on this case? Is this too basic for you, or what do you think?
It's not too basic for me. Rolando, Genesis was, at the end of the day, a good idea. So we don't want to fuse, but at the limit, we create an ankylosis. So, and with screws. It's not my, even Gilles Dubois is a great friend of mine. I have never been very satisfied about that. Back to your case, I would take off the Genesis and I would put the disc on 2 levels.
Okay.
But
Hey, Rolando, looking at
it's
the second.
I have not seen the patient, and it's an indication of a guy at the opposite side of the world in front of his computer. He's not in charge, but I would say theoretically the best would be to do that.
Rick, go ahead.
Rolando, and if you look at the second X-ray from the left, it looks like the left or the right facet is partially eroded. Now, I don't think that's going to compromise results, but that's kind of interesting. I've never seen that with the denesis.
Yeah, I definitely, looked at that, and I guess the comment is, at what point is there a percentage at which you would say, we just can't do it? What do you think?
I think that's fine. You have actually more than half the facet left, and I'll go up to half a facet as long as they're not grossly unstable. Him, you don't know how unstable he is. He's just not moving. So I think your idea to do the disc replacement is.
So, so basically that's what we did, and you can see the staples has an early post-op X-ray, and you can see that ideally you would have put less lordosis on the implant at L5S1, but this was right after surgery, so he was still a little bit tender on extension. But you can see here that about 6 weeks, I was able to get quite a bit of motion and very nice, I think, result, at least from a clinical standpoint, something that this X-ray is a few years old now, and something that I need to start doing is more of the parameters that Thierry is teaching us about with the L1 raise and the, but obviously, at least from a segmental mobility standpoint, you can see that this was, quite different to the pre-op. If we go back to the pre-op, and then we see that now he's have quite a bit of motion.
All right. So may I ask a very provocative question?
Sure.
The active L that you helped design has a constrained mobile core. Do you think you would have gotten that good emotion with a fixed mobile core like the Pro Disc? And I don't mean to put you in an awkward spot, but I think this is a brilliant result. And I personally don't think that you would have gotten this good a motion result. Clinical result may be identical, but in terms of motion, this is an absolutely perfect indication for a constrained mobile sliding core.
So I think that the purpose of these educational exercises is to have these honest discussions, and I sincerely think that you would get motion, but you would not get as much motion with a fixed core. And obviously, I'd love to hear from Thierry about that, but I do have that opinion.
Terry, what do you think? Terry?
Yes, I'm thinking about my cases and trying to think if I can compare to that. I will not So I think it remains stiff in flexion. That means that we have a good motion in the space and no great motion in the spine. So the space are moving, but the spine above is not enrolling as I would like. You see the sacrum is fixed and doesn't participate to the flexion. So we have not here, but a pelvic enough pelvic range of motion restoration. But it's not because of the design of the disc. It's because of probably the stiffness of the patient operated by posterior approach. You imagine that in front of the surgery there is a fibrosis. You know that you have taken off the instrumentation. And this fibrosis lock completely. There is no posterior elasticity of the soft tissues. But it's not only on the level operated on. We cannot think that we go to elasticity of the muscles, retraction, and after that, a new elasticity of the muscles that affect all the chain. And that's why the first shot is very important, and we have not to operate backwards, thinking that, oh, if it doesn't work, we will go front to put a disc. No. We create the scar inside that is that will never be withdrawn. So that's why you have this apparent good result on the space, and you don't feel that the spine wants to move a lot, but it's not because of the disc, it's because of the posterior scar in the muscles.
So Thierry, two questions about that. Number one is that, do you think that, do you have a specific way when you get the x-rays? Because we do have in our office a very specific way. They lean, they grab on something. Do you have a specific way for getting your flexion extension x-rays?
I try to convince the guy who is performing the x-rays, who is not a radiologist himself, but probably it's easier to do. If he's not radiologist, he will listen to me. To take first the hips inside of the extension flexion, and second to go to L1. So the film must be a bit bigger and sometimes larger, because it's very interesting to look to what happens even in flexion extension to the incidence angle, because in some patients it moves, and to look and to be able to measure L1. By chance, I had a lot of cases, hundreds and hundreds of cases with that type of pre-op and post-op measures that helps to make people that made me understand what I have to describe, because if I have not that type of x-rays, I couldn't have described that. So it's the same for me than the spinal balance. This my boss has not made during years total lateral film, including the hips. I would have never described that in the 80s. So it's a chance to have sometimes good x-rays, even you have not designed the protocol to make them. So can put the hips, we can put the L1 at that moment, it will be good. And there is something important. Typically, when you ask a dynamic, in extension, the guy who is making the radiology in your office doesn't limit the patient in extension. But when he sees the patients who has been operated on bending like that, oh, stop, that's good. And so you will have never what is the limit of that. So perhaps this patient has not started this pelvic motion because the guy who is manipulating the X-rays room says, stop. No. Typically, it's good to, in the protocol, when it's important control, 6 months, 1 year, 2 years follow-up, I take the patient first before the X-ray to make him simulate what I want. So in the radiologic room, make your extension perfect, and perhaps your hands on your neck, and go and as much as possible touch the floor.
Okay. Terry, there's just a couple quick questions. Roland, somebody asked whether or not there was still motion at the denesis level when you took it out. In other words, did you find it to be stiff? And the second question, maybe you and Terry can answer. They were questioning whether or not you get flexion with the patient sitting or standing. We know what the answer is, but just answer those two questions, and then we'll move on to your next case.
So there was obviously the first part of the case was to remove the denesis. So by the time the denesis was removed, the disc was very mobile, and the X-rays we do standing.
Okay. All right. Roland, do you want to go on to your last case? We got a little bit of time.
Actually, this is the last case, but this was just
Okay.
a couple of points. First, and I was jokingly saying that maybe we should get paid for a Smith Peterson osteotomy when we do lumbar disc replacement, because obviously you have a very significant, you typically get 9 to 10 degrees per level for a Smith Pete, and here you can see that someone walking around with with a significant amount of loss of lordosis is going to be working a lot harder than that people on the right. And then finally, obviously, I think these are my thoughts, but I think that Thierry is well past my future. But I think here in the US, the future is obviously multiple levels, not necessarily 5. We can see, and I think Thierry did a phenomenal job about talking about it, that we're starting to push a little bit of the envelope in terms of facet degeneration. And I know I've had conversations with Jack, with Rick and Scott, and I think that we both feel that maybe we have been a little bit too stingy on that deformity that obviously Thierry did a great job to talk about. And then something that I wanted to ask Thierry here, I'm sure Todd is maybe participating, listening to this, but this is article that came out where someone took down an A-lift, Todd Landman from LA, and put in a disc. Thierry, do you have experience in converting fusions to disc replacement?
Not a lot, but it's for legal reasons. If I have a problem doing that, they would have taken my license, and my insurance will not cover me. So no, it's too risky. I have done it. It works well. You have to restore the mobility. You have to see the facets are not fused. Typically, they are not. There is a lot of. You have to get a lot of conditions to do it. And especially, you have to be sure that the patient will use it. Because if the guy is just to go, we are in France, from his small apartment, small flat, to the bar, down, play a little bit with the balls on the area, and back to take some to take some pasties or things like that at home all the day, he doesn't need you to take the risk to do that. If the guy wants to move, he wants to recover a sport activity, he wants to recover a job, at that moment we can take all the risk. I know that in the United States, people have to work. In France, sometimes with the compensations they have, a guy who will get 5 levels will get the maximum of pension. The first guys who is he will visit for his compensation. So, with that, how you can live with that in your back? My God, it's your doctor has made crazy things, so he will be compensated. So, you have to choose. The more we have to invest invest ourselves in the patient, the more we are sure that we are not doing that for nothing. It's
All right.
Rolando,
it-
quick technical
and-
question. Do you do
Yeah.
a release of the posterior ligament or do you resect it? Because you had very exceptionally good motion of the posterior intervertebral space.
So I typically do release it, do take it down. Basically, make a point in taking the carousel, turning it sideways. As you know, it's getting the plane. Once you get the plane, it takes about a minute and a half just to come across. And I think, I'm sure that you guys have more experience than I do about that. But once you take down, I try not just, I've tried, and I think Rick taught me that taking the curette and releasing it from the backside. I think that works well, but I do think I get a lot better motion when I just take the carousel and I literally go around. I don't even, because it's soft tissue, I don't go in and out. I just literally keep, like if it was a scissor with a carousel, I just go across.
Terry, you're shaking your head. Do you do the same?
Yeah, important for those new have the experience of total hip replacement. You don't let the thick capsule around your prosthesis. You make a complete resection of the capsula because it's thick. At the beginning, they were using and wanted to suture the capsule around their hip, but they were very, very stiff because the capsule is thick. There is no more elasticity. It's fibrotic and calcified. It's the same for our ligament. So at the beginning, I was 30% of the time letting the ligament. I think now is 99% of the time the ligament is out, even in when the disc is black height and only 30% of collapse. I think the release is very important.
All right. Any other last question? This was terrific, Terry, and terrific, Rolando.
Thank
And
you.
Terry, thank you very much for staying up late. I know it's 3 a.m., so
Oh.
you better get some good sleep.
No, but now I am awake to recover. Oh, I was very glad to share that with you. I will always be your man